Thank you, respected panelists, chairpersons, and respected speaker. And with that, we will move on to the next session for today. The next session would be chaired and paneled by Dr. Anil Mishra, Dr. Devdatta Bhattacharya, Dr. Arunangshu Ganguly, Dr. Ravindra Bhattacharya, and Dr. Debubrata Bera, requesting all our respected panelists and chairpersons to kindly join the session. And the speaker for the next session is Dr. Indranill Basu Roy from USA, and he will present his talk on cardiac contractility modulation, a new kid on the block. It's a pleasure introducing Dr. Indranill Basure, who is a staff cardiac electrophysiologist and the director of cardiovascular research at the Memphis VA Medical Center and an adjunct professor at the University of Memphis. He is also visiting professor of cardiology and head of integrative cardiology at the All India Institute of Medical Sciences at Rishikesh, Uttarakhand, India. He is a faculty mentor at the MIT University in biomechanical engineering to help developing newer technologies for cardiovascular disease therapy. He's also a practicing yogi and meditator trained in the Kriya Yoga meditation and is the editor-in-chief of the world's first book called The Principle and Practice of Yoga in Cardiovascular Medicine, written by over more than 75 physicians from the world's top medical centers, including Harvard Medical School, Emory, AIMS New Delhi, and PGI Chandigarh. Dr. Indranill Basu Roy, we are all waiting to have delightful learning from your end. Thank you.
Thank you very much. Okay, can you guys see my, I'm sharing my screen. Can you guys see my screen?
Yes, we can.
Okay, thank you. Dr. Shubhra Banerjee, thank you very much for having me. Dr. Anil Mishra, it's a pleasure seeing you again and the entire team. Let me start my first slide. Can you guys see my screen now?
You can.
Okay, thank you very much. So heart failure, as you guys know, is a global pandemic affecting over 64 million people worldwide. Currently in India, as far as I could find the data, there are at least 8 to 10 million people in India who have heart failure. And the prevalence, unfortunately, increases with age. And every country in the world, including India, though India has a lot of young population, every country in the world is aging. So is India. Whereas the number of heart failures is around 1% for people under 40, it goes up to 20% in people who are 80 or older. US currently has 6.2 million people with heart failure, and by 2030 we'll have 8 million. It's supposed to be around 12 to 15 million by the time it's 2050. So this is a progressive epidemic, and it's very important to understand that. So without wasting time, I'm going to talk about one of the latest updates, one of the frontier of medicine treatment for heart failure, which, as all of us know, thanks to the talk even in our the last speaker, that it's a bad disease, it's a nasty disease. And unfortunately, even physicians don't understand that heart failure prognosis, if untreated, is worse than all cancers known to mankind other than pancreatic, gastric, and a few gastrointestinal cancer. So if that bad is this disease, how come we're not having a better treatment for it? So let's understand where CCM or cardiac contractility modulation fits in. So this is the panorama of people with heart failure in the US. And you can see class 3 has got almost 2 million people. And if you add this number to the Indian scenario, maybe twice the number or thrice the number will be the number of people with these symptoms in India. Now, out of that, 30% are class 3 in the entire ref set of people. And out of that 30%, unfortunately, only 33% are actual candidates for CRT. But unfortunately, quite a bit of them, almost 30 to 40%, can also be non-responders despite having CRT. So even if I take that 33% do respond to CRT, you still have 67 or overwhelming 70% of patients who are candidates for CCM. But it's also important to understand there's a big number of patients who had CRT and they fail, and they also become candidates for CCM, like some of our patients, as we shall talk about. So, for a simple understanding for a cardiologist or a cardiac EP to understand where does CCM fit in. So, we have heart failure, we have stage class 3 heart failure. If they are in normal sinus rhythm, you look for their QRS. This is a busy slide, but I just want to give the gist. You look for the QRS. If the QRS is more than 130 left bundle branch block pattern, go for CRT. CRT. Of course, in a very small set of patient, you may not have the branch of the coronary sinus at the right spot, but that's a very small number, and especially with newer techniques, it's almost possible to go almost anywhere. And now some of the leads have come in that can be screwed in. So with all those advantages, CRT has become a good modality. But despite that, there's a big problem. What is the problem? A large majority of the patient do not have prolonged QRS. What do you do for them? CCM is the answer to them. Now, I've said sinus rhythm here, but there are some studies, but I purposely did not put it here, that shows that it might actually help in people with atrial fibrillation and who are rate controlled. And there's one case report which says it even decreases the incidence of atrial fibrillation. But we'll not go into those controversies now. Let's talk a bit more about CCM. So this is the core slide. You have anybody between 25 to 30, 45% sinus rhythm, not a candidate for CRT, you go for CCM. I'm not going to go through this other than the last line, which is very important to understand because the concepts about heart failure has changed. There's nothing really called recovered heart failure, because whenever you say it's recovered heart failure, the whole definition seems to tell you that the patient had a disease and he is cured. You really don't get cured. What we always call is almost similar to cancer, is we call it heart failure in remission. And that's important to understand with this newer heart failure therapies, that the patient who has developed heart failure, serious heart failure, he needs to be treated the rest of his life. Whether you treat him using CRT, CCM, or just drug therapy doesn't matter. But that's an important concept, and we'll come a little bit to that in this slide also. So if I look at the trajectory of heart failure, unfortunately is one of those diseases which we can divide basically into 5 different stages. The initial stage is when they start have initial symptoms and you start them with drugs. Multiple medicines are there, and then you go to stage 2 where they reach a plateau. So the medications might work, might not work. They may be symptomatic, they may not be symptomatic. They can start having hospital admissions, but there's a plateau. And then there is functional deterioration. When the fascia starts deteriorating, unfortunately, there are multiple hospitalizations. And almost like vascular dementia, as you know, nobody reaches the base. Every attack makes it worse and worse. You get caught in the vortex of worsening heart failure till you reach stage 4, where there is severe refractory symptoms and limited function. At that point of time, you can go for a VAD. Nowadays, some people use destination VADs for those who are not candidates for transplant, or you can go for transplant. But if you look, so this is where you use VAD or transplant, and they come back to stage 2. But it is important to understand that throughout this period, this arrow shows where people can still die due to sudden cardiac death. Now let's go to the mechanism. I picked this from the ESC because it's a little older. We have ACC even later than this, but to give you guys an understanding of the overview. So we know you're going to give all the 4 different pillars of the drugs we all know. And then for LBB, more than 130, you go for CRT. If they have AFib, you refer them for PVI. Rare cases, you might need to put them on antiarrhythmic drugs. We prefer doing PVI so that there is massive indication that PVI increases. If you kill the AFib, it increases EF. It prevents the vortex of going into severe failure. But then when all these fails or your QRS is less than 120, what you do? That's where CCM comes. We have another technology that is evolving, that is BAT. I'm not going to talk about that today, but that's what my talk will be on. And then there are a couple of newer drugs like Vericiguat, but we'll not be describing it today. So let's understand what CCM is. CCM is basically a technology which delivers timed energy pulses to the heart. And the biological effect, fortunately, is seen in days, and that's the miracle. And I'm going to talk about actual patients to show that not, I mean, I've been treating, being a cardiac electrophysiologist, I've been treating tons of heart failure patients all my life. I have never seen such miraculous results. Now, you ask me how long are they going to last? Only God knows, because we don't have any long-term monitoring as yet, because the whole concept is brand new. FDA approved it. We are just starting to put things in. We are just starting to put them in patients. But the initial thing is extremely promising. And I'm going to just give you some of the idea as to how it looks as I see in my clinical practice. So this is what CCM does. You can see this. This is the complete refractory period, part of the ECG where it's refractory. And if you look at the action potential, this is when potassium is coming in, the heart is refractory. At that point of time, if you give them a massive pulse between 5 to 7 volts, up to 7.5 volts for at least 20 milliseconds, that's the basic work which cardiac contractility modeling does. Now, why do you do it? Generally, we put in the leads. I'm going to talk a little more about that. I can answer a question if somebody has. We put like a pacemaker inside the right ventricular septum, but it's quite different from the pacemaker, and I'll be talking a little more of that. The problem is you cannot go too high. If you go too high, patient will start feeling the symptoms, because remember, you're giving 1400 to 1500 times more power than what a normal pacemaker uses. So it cannot be too high. It cannot be too close to some other leads that you might have. Like my patients had a CRT, failed CRT, and then we went for a CCM. So that's where we put, this is an open heart showing that. So this is the actual device. You can use any lead. You can use a Medtronic lead, St. Jude, Boston Scientific, Biotronic, name it. Leads are not important. Any of the third vendor leads can be used. This is from the this is not my case. This is from the circulation, but my case is similar, and I'll show you. This guy also had ICD, and on the right side, they put in a CCM. And that's pretty common, because a lot of patients here who have had CRT also have failed, including my first patient. And we went for a CCM because he was severely symptomatic, couldn't even go from his bedroom to his attached bathroom without being severely breathless. Now, how does it work? It increases calcium metabolism, and we'll talk about that a little bit. But before that, let's see the EKG. If you look at the EKG, this is what you're going to see. So when the CCM is off, this is the normal QRS. But when the CCM is turned on, you're going to see these spikes. And these spikes are those at the refractory point, you're giving a hit that lasts for at least 20 milliseconds. The amplitude is plus minus 7.5 volts. You can manipulate it depending on how much you need. But remember, as you all know, being cardiologists, it's never ever on the T wave or any part of the cardiac circuit which can cause arrhythmia. So it's not known to be arrhythmogenic. This is the initial studies we had, which actually showed that the left ventricular pressure increases because the left ventricle starts contracting more. And if you look at the molecular calcium at the cellular level, there's a massive increase. You can see this is the baseline, the blue is the baseline, and the red is the red is the with CCM. So what CCM does is basically what you do is you give them 5 1-hour delivery of the electric current, and then you put them on rest between around 3 to 3.8 hours in between those pulses. And you can charge the device weekly using a Bluetooth system. So it's not that you have to open up the device and charge it. It's through a Bluetooth system, it can be charged. And that's how it works. Now, how does it work? I don't want to go too much into molecular biology, but just for the understanding of people who are interested. So there are two or three big problems with heart failure. See, as you know, I mean, as people develop heart failure, there are changes in gene sequences. The gene sequences change from adult genes to fetal genes. And that fetal genes all of us had when we were in mother's womb. But because the heart was basically a passive organ as a fetus, and then it starts becoming an active organ. So what happens in heart failure is progressive damage. Slowly the genes gets transformed into fetal genes. And some of the important genes that are involved is the sarcolemmal gene SARCA, which actually activates potassium picking up from the cellular medium and releasing calcium also. And then there are other additional genes like the NOx, which is the sodium calcium channel that helps bringing in calcium, and then that increases contractile force. As you know, if you have more calcium, tropomyosin will be bound, and then bounding tropomyosin will make actin myosin to come across each other, and there'll be more contraction. So it's a very simple mechanism. What this device does is by giving this active pulses, it changes the genetic sequences, activating all these genes, including SARCA, NOx, and also the ranitidine gene, causing more phosphorylation of the phospholamban. So both these, the total calcium handling increases. This is a good article from Nature. If anybody is interested, can read it, and I can pass this on to Dr. Banerjee, and this can be anybody who's interested in understanding the mechanism. It's really interesting. But this is the most interesting part for us as clinicians. The result is rapid. Within minutes to hours, you will find there's an electronic spread of signal, there's rapid phosphorylation of key proteins, there's improved calcium cycling, and the contractile force increases. And we have seen this using echo. There is no increased myocardial consumption. So this is not a device, unlike quite others, that increases contraction, but also increases myocardial consumption, leading to more ischemia, particularly in patients with ischemic cardiomyopathy who could not be fully revascularized. And more importantly, this is the first known therapy for heart failure known to mankind that actually causes a shift of the gene program from heart failure genes or fetal genes, which actually are, I call them normal genes because all of us had those genes when we were in fetus, to the adult genes program that is seen in a normal adult. And of course, this results in global improvement in contraction. In weeks to months, there is a beneficial effect. And in our patient, in 3 months, he started with a EF of 20-25%, and in 3 months, echo showed 40-45% EF. Now, what are the clinical data supporting? There's a bunch of studies. It'll take a long time to go through all of them, but I'll just pick up some important facts that will help you understand how important this newer therapy is and why we should all go for it. So first thing is that it does help patients who are worse in the pyramid. People with EF less than 25% benefit the most. That's a very important thing. There's improvement in ejection fraction and all the factors. Second is that cardiac contractility genes, as I said, improve. All the bad genes that get upregulated, they start getting downregulated, like ANP, BNP, NOx, and all the good genes that were downregulated gets upregulated. So what happens is like SARCA, MHC, PLB, that's phospholamban, RYR2, that is ranitidine. Remember the ranitidine receptors plays the most important role in calcium cycling. So all these genes are upregulated, causing increased contraction. Now, what does this result in? What is the core answer? The core answer is if you do study at the cellular level, and unfortunately or fortunately, this is done in humans. These are not done in animals. People have taken biopsies in countries, of course not in America, because I don't think this would be possible to do it in America. And they actually showed that the SARCA protein level, the PLB, after treatment and off treatment. So it was a double blind. They put it on, then they put it off, then they put it on, and during off and on, as you can see, these are all on. I don't know if you can see my my arrow. And with on, all these genes are upregulated, whereas the bad genes, as you can see, gets downregulated. So this is one of the largest study, which took 160 patients. Primary efficacy was peak VO2, safety endpoints, any complication, and efficacy endpoint was Minnesota Living Score. So of course you can see these are soft target. I don't know how many of you in the EA are electrophysiologists. If you remember the first 10 years of CRT, that's what they did. They took only soft targets like a 6-minute walk, Minnesota Life Score, peak VO2, And then they went to more harder outcome like mortality benefit, MACE, and all those things. So this is the same picture we see here. Initially, they took PVO2, QOL, and functional status, and there were a massive improvement. But this is something I want to show you. This makes a lot of interest, is that if you look at the PVO2, if your PVO2 was greater than of 35%, then your response was much better. Um, uh, much better than when PVO2 is less than 35%. So I'm going to maybe skip some of the slides and go. So this is the cardiovascular death and heart failure hospitalization. This particular study clearly showed that the event response in control, which is red, is way more than in CCM. This is a study from the cohort registry that shows hospitalization 24 months post-implant and 24 months post-implant in 35 to 45% patients in people with EF 25 to 45. You can see the difference. So it looks like people who are borderline, like 35 to 45, who are not candidates for ICD, but they are going to get a progressive course. If you are aggressive and if you put them CCM, they will come back to normal. Remember, as we said, heart failure is not a cured problem. Heart failure is only a recovered, not even a recovered problem. It's a remission problem, just like most cancer. So you cannot say, okay, this guy is 35 to 45 now, let's let him go. No, he has to be still under treatment. And if there is therapy available that will increase it to normal, along with continued GDMT, that's what the idea should be. And this slides prove that point. So this is our patient. You can see the device, and I don't know if you can. I'm going to play this again. You can see there are multiple wires. What are these wires? So this wires, if you can see my wire, is the CRT wire. In this, he got CRT around 2.5 years back. This is an old pacemaker wire that was not being used. This is his ICD wire. You can see the thick coils of ICD. And these two wires that you see, these two are the wires we used for his CCM.
Medical breakthrough.
So this guy is this guy, as you see.
Activis, much more.
CCM stands for.
So this is a guy who's severely symptomatic, could not go from his washroom to his bed in the same in his attached washroom. In 5 days, he could go to his washroom alone. He could go and pick up his letters from the letterbox, which was 100 feet from his house. And in 1 month, he could walk 2 blocks. He came back in 3 months, and his EF was 40 to 45%. So summary, it's a first disease-modifying electrical therapy known to mankind. Based on the candidate would be anybody with MIHA class 3, EF between 25 to 45%. There is improvement in QL and functional status. There is signal, but not actual data, because we need to do more studies that it actually decreases hospitalization, may decrease AF burden also, but those are based on extremely small and particularly AF and some case reports. Thank you very much.
Thank you very much, Dr. Indranill Basu. Nice to see you again. And it was a wonderful talk. And we are all really excited about this new therapy. And because we know early days of CRTD and CRTP, there's a lot of excitement. And the same has come back 20 years later to much more number of patients. To start the discussions, there are a few questions. First is, of course, we still do not know whether they will have a mortality benefit. Do you think it's like CRTP early days that you only showed improvement in quality of life and symptoms in NYHA class, but down the years there will be studies which will show mortality benefits?
So as I said, mortality, we know clearly from tons of results that is based on hospitalization. There is, as I said, already quite strong signals that hospitalization is decreased. If hospitalization is decreased, we can certainly expect there will be a decrease in mortality. The second factor that would come into play is the fact about the changes in genes. If we can show, and unfortunately we do not have any long-term study, that this genetic sequence remains as it is as in an adult, we believe there will be a change in mortality, because all the bad mortality guys, the guys that cause increased mortality, like Noradrenaline level is almost 9 times more. The angiotensin 2 level is more. ANP is more. As you can see, the ANP gene itself is deregulated, and that's a miracle. So if this lasts for long, we expect there certainly will be some improvement in mortality and certainly some improvement in hospitalization. But it's a little too early to say that because unfortunately nobody in the world has got long-term data on this particular device.
Yeah, it's interesting. In one of the studies, we saw that even placebo had equivalent almost effect for the first 3 months, but then that weans off, whereas this sustains. But why is that? Such a good placebo effect for the first 3 months?
No, I don't think so. The reason is this guy, you're right, placebo does have a good effect. But what is difference between placebo and this is placebo mostly comes with symptomatic improvement. But you do not see any marker improvement. For example, you don't see any 6-minute walk improvement. People might say that he can do the 6-minute walk a little better, but the number of distance covered is never better. So that's the difference between a placebo and this particular thing. Secondly, what we also see, as you saw, we had human biopsy taken to show increased difference in the genetic expressions. So that is never ever seen in placebo. So it is true that some of these effects could be due to placebo, but I think given the fact that we actually have proved that actual biological and cellular and molecular markers get better, I don't think this is can be said that this is exclusively a placebo. And the other thing is that, remember, most of the placebo effect sort of fades away after a couple of months. But this has been there for a couple of, around a little more than a year now that we have been using it. It's there and it looks pretty sustained till now. Now, if you tell me, will it last for 15 years, 20 years, or these guys will be cured forever? Unfortunately, I don't have an answer for that. But in the short term, if something lasts for a year or two and the EF remains at 40, 45, because the other problem also you have to remember, like in my patient, his EF was so low, his pressures were in the 60s, 70s systolic. I mean, he could not be on full dose carvedilol. Now he's on 25 BID of carvedilol. He's on a full dose of Entresto. So your GDMT also gets better. So what this does is not only it improves the sequences, it also accentuates the effect of your GDMT, making sure that your patient gets the full-blown good effect of all the GDMT, including Jardiance. His kidney function, by the way, improved. So he's on Jardiance. He's on all the 5 drugs, as well as he's now on CCM. We kept his CRT on because though the CRT, as you say, basically failed, he's those poor 30% guys who are non-responders. So that's what it is. So it's not only the device improves heart failure, but device accentuates all your other older therapies like GDMT.
One practical problem I see is most of these patients would have one of the devices on the left side, which would be CRT or CRTD, and you have another device on the right side. You have a combination of 5 leads. So, what do you feel about it?
Yeah, no, that's absolutely true, but that's going to go away. The company has just applied for. Can you guys hear me?
Yep.
Yeah, they just applied for FDA for a device that will have both ICD and CCM together. So they can put it on anybody below 45 EF or below 35 EF, depending on your patient. So that should be there in the next 6 months to a year. I guess the FDA will allow it because it's the first device in the world combining ICD with CCM. So then this problem will not be there. My patient, unfortunately, is a guy with heart failure for 15 years, failed GDMT, had CRT, failed CRT. So we had to put it on the right side, as you saw. But you're right. Most people, you put it on the left side. With the newer devices, you could just put in one device and you're done.
I have my co-chairmen. Could I ask some of my co-chairmen to ask some questions if they have?
We really do need to put that atrial or just to set the leads. But we need to put an atrial lead or the 2 septal leads of leads.
Yeah, no, you can do a couple of things. You can put an atrial lead, or you can just cap the atrial. Can you hear me, Dr. Ganguly? Okay. Yeah, you can. So you can cap the atrial port, if you do not. But in the new leads that is coming up, as I said, the one which has got ICD CCM, ICD plus CCM, there you will put in an atrial lead just like any other, and you'll put a. In this case, there are two ventricular leads, and the two ventricular leads are put in the septum, lower part of the septum, but not too close to the tip of the apex. At the same time, they should be 3 centimeters from each other and 2 centimeters from any ICD leads, so that there is no interaction, because you're giving massive power. So you should not cause the ICD leads to pick them up. Like you saw my actual movie, you saw how I placed them. So that's how it is. But yes, atrial lead, you just cap the atrial lead. And in the future, as I said, atrial lead will be just used like what you would do for any other patient.
Right. Another quick questions. Basically, is somebody working on a single lead delivery?
No, the reason is that there is an understanding now, the more area of the septum you cover, the better. So with a single lead, if you the coverage will obviously be, so there's a conundrum here. One is you have to cover as many lead, you have to cover as much area as possible, the electric current.
Okay.
At the same time, it should not be so widespread that you affect the ICD lead. So with this conundrum there, you have to use as many area as possible, at the same time not affect the lead. Possibly it will take time to have a technology that can do both. So that's why they use 2 leads. And also remember that we are giving a sinus wave, both positive as well as negative, 7.7 volts on each side. It's not a single, it's a double biphasic. So that's why it is easier to do that with these 2 leads.
Right, thanks a lot. A wonderful topic and a very interesting insight into it. I think we should wrap up in interest of time. There are lots of more questions which we can ask some other time. We'll carry on with the next program. Thanks a lot once again, Dr. Indranill Basu. Congratulations for such excellent coverage of the topic.
Thank you, Dr. Mishra.
Thank you, Dr.
Dr.
Mishra. And with that, we will readily move on to the next session. And